At Central Manchester University Hospitals, the Trust was convinced that appropriate technology could help make a real difference to patient safety. The Patientrack system was selected after an extensive trial and is now being rolled out across all adult and children's wards within the Trust. Patientrack is designed to improve the recognition of and response to acutely ill and deteriorating patients. This is the story of Patientrack at Manchester, told by the doctors and nurses who use it.
When we go to do the observations, we take the PDA with us. The observations are done in the same way as per Trust policy. We have a standard of how observations are done.
Hiya, my name's Simon. Is it Anthony?
It is, yeah.
Yeah? Alright. You've had an operation on your right arm, haven't you?
The observations then put in onto the PDA. We take the blood pressure, the pulse, the respiratory rate, the saturation, the temperature,
Just your temperature, just sitting.
and a neurological assessment as well. The PDA automatically calculates the early warning score, and that will automatically be uploaded onto the TPR chart and onto the system itself. If someone does trigger and gets an early warning score of 3 or more, the immediate call will go out. So in some cases, before you've even put the system down, someone else will be able to come along and respond to that patient's alert.
We've just had an alert. Has he triggered?
Yes, on his respiration rate and his temperature.
Yes, I can see that. The observations are available then onto the system, so you can see them on the computers.
You all right there? Okay, smashing. We'll read the observations in a bit. We'll get some paracetamol, which will be a bit cooler. Okay.
So you can see the observations even in your office if you so chose. Automatically, the observation frequency is assigned as per the Trust policy. This can be changed if you have somebody who's post-operative or who's had to bang their head or anything, and that can be set into a template that we have pre-written. Any observations that are due will show up on the system, and as it gets delayed, it'll change colour, so you can very quickly and at a glance see if someone's observations are overdue. If someone does trigger and gets an early warning score of 3 or more, the frequency will automatically increase to at least hourly.
We know from experience throughout the world that there are a group of patients, a significant group of patients who have unfortunately been deteriorating often-wise for a number of days, and that deterioration has not been recognised or indeed acted upon, and for that group of patients they are at significant risk. The identification of these patients from their pulse and blood pressure is sometimes not so subtle, and what it requires occasionally is for somebody to recognise totally abnormal figures and raise that alert, either in themselves so that they can do something, or indeed in somebody more experienced or with a different skill set so that they can intervene to stop the patient's decline. We have for a number of years used various forms of track and trigger tools to look at these what we call physiological variables, pulse and blood pressure, in order to sort of set thresholds for calling for help. And what we know is that even when we set fairly low thresholds for help, people still are reluctant or unable to actually call for assistance for that individual patient. The use of technology allows some of that communication to be done automatically. What it does, and certainly what we've found from our experience of Patientrack, is that it helps people to actually raise a call because it's the system that's doing it for it. When we were approached by Patientrack with a view to looking at their software, we felt it was probably best to actually trial it rather than to actually just implement it. We trialled it in our medical assessment unit and one of the medical wards beyond that. So we recruited some 700 patients in each of the groups, and between the baseline group where we identified length of stay as our primary outcome and the length of stay in the intervention arm, well, basically we just turned on electronic alerting. We found a significant reduction in length of stay for that group of patients. There were some other outcomes, the secondary outcomes, and they too showed benefit, mostly in critical care admissions and length of stay. We saw some softer things like a reduction in what we call chain length, which is essentially a very simplified way of looking at how long patients are being ill for. And so we saw reductions in that, and so we took away from that this kind of electronic system would enable us to identify patients quicker and to manage them earlier into their deterioration so that they were more acutely unwell for a shorter period of time.
Well, we've had lots of preparation, so we've known it's been coming for a long time. What we've aimed to do is to inform staff that these changes were coming on board, and I think this has been a big help really, that the staff have adapted to this change really well.
He seems to be getting much better.
Within a short space of time, probably 6 training days on the ward, we were able to move to a paperless system. Thus the observations were all completed at the bedside with the handheld device, without the need to document them onto a traditional temperature, pulse, respiratory paper chart.
We had paper observations charts and the computer observation charts for around about 2 weeks, just so the staff were allowed to get used to using the machines but had the paper as a backup, and then we slowly withdrew the paper versions and kept the computer versions. During all of this time, the Patientrack team were on the ward every day, giving training, and if there was any problems they would rectify them immediately.
Initially, I think it felt like quite a big change in working practice, and quite a few people were a bit unsure about what it was, but there's been lots of training, and I think particularly now we've been able to see the data that we can get from Patientrack. A lot of people have really taken it on and are really quite enthusiastic about it. With any change in working practice, I think there's always going to be difficulties and challenges. There was a lot of work done with the nurses on the wards in terms of getting them trained in using the system and getting them to a good standard of acute care. I think it was a bit more difficult with the junior doctors because we are a more disparate group and we're always on call or on night shifts. So because of this, we've devised a role to go along with Patientrack, whereby the certain doctors on the wards will get extra training to be able to train other people, other doctors on the ward, so they can catch them on the night shift or when they're working. So I think as well as being a system that's been implemented to try and get patients seen quicker, there have been other benefits in terms of just getting people to focus on the acute care training and knowledge of all the staff, including junior doctors.
Once the alerting actually occurs, and this alerting is the reason that Patientrack was so attractive to us. People respond very quickly. People have responded before we've even left the bedside on occasions, which is really, really new. Previously, we could spend ages on the phone trying to find a doctor, and you may not find them for some time. So that response has been really, really useful. It doesn't stop alerting either. So if someone comes and they aren't able to improve that patient, it'll continue to alert until the right person, until the very senior person comes along and sees that patient. So all the time you know that there's going to be a safety net there to catch your patients and no one will slip through the net. Yeah, one of the other really good things about Patientrack is that we can see the observations from wherever we are. So I can check in the morning first thing and see who is sick in the hospital. Not just who's sick, but who needs observations doing. And you can see other things from that. It may be that the ward actually is really busy and struggling. So by visiting them and making sure they're okay, you can assess that.
I think it has really settled down. I think people are getting much more used to it. And certainly on my ward rounds, we just take the tough book around with us and we use it for bringing up observations and things. And it feels fine. It doesn't feel much different to perhaps the paper observation charts and things. So.
We found that it's freed up a lot of nursing time since we've had it, because when a patient is unwell, we can actually spend our time looking after the patient rather than having to bleep doctors, chasing bleeps. The machine does it all for us and we can just concentrate on the patient. It is very strange. I was moved to another ward where we haven't got Patientrack, and I actually found it very strange even just after a few months going back to paper. You know, little things like having to work out my own early warning score because I'm so used to the machine doing it for me, and where I was charting it all because I'm not used to writing it down anymore.
Whereas before Patientrack, you used to have to ring people, persuade people, and get on the phone and really state your case as to why you wanted a review by intensive care. Whereas now it's just an automatic thing and patients get reviewed very quickly, which is an amazing thing to have achieved.
It doesn't de-skill. I mean, we still have to do the observations, we still have to do manual blood pressures, and in some ways it has given more skills in the fact that we've been on these extra courses. Nurses in charge on the shifts are able to prescribe small boluses of fluids for patients, which we weren't able to do before, so it's actually given us more skills.
One of the really important benefits from Patientrack that I wasn't really aware that was going to happen was when that initial trigger goes off, the nurse in charge of the ward often didn't know that patients were getting sick, and there's a really obvious and useful learning experience that's occurring here now. So a nurse in charge will go to that patient bedside straight away and talk to the nurse, and they'll find out and together be able to look at how they can improve that patient outcome. And that's meaning we're seeing a lot more of patients being able to get down from just a trigger to better by that nurse interaction, rather than it having to deteriorate and get a medical response. And that's been something that was not really expected, but a really clear, obvious improvement to the patients.
I think Patientrack is a really innovative system which is really looking to try and help solve some of the very long-standing problems that have always been present in hospitals. And I think by bringing Patientrack in, not only are you forcing people who are sick to be seen sooner, which is absolutely the intention, but there's all sorts of sort of ramifications in terms of recognising weaknesses within your own system and then being able to deal with them, and also being able to focus on acute illness and training and making sure your staff are up to date, all of which has benefits.
Another benefit that we've seen is that the senior doctors get to know about the sickness of their patients. This didn't always happen before. There were times when the escalation didn't get up to that level because people felt they could cope, or they didn't need to refer on, or they just didn't want to disturb their senior doctors. Now this is meaning that they haven't got that option. It automatically escalates, and that is really clearly important. So the right people are coming to the bedside, so it's benefiting patients and it's benefiting more junior medical and nursing staff, ensuring the right person gets to the right bedside all the time.
The response from the clinicians who are coming is increasingly more mature, and they now recognise that actually all they're doing is coming to see a patient that they would have seen, but they're catching them earlier in their illness.
So is that its chart?
Yeah, have you seen her?
Yeah. The best thing about it will probably be the fact that from where we were trying to get clinicians to come to see patients, this works because it gets people there.